Welcome to this very short talk about Central Compartment Atopic Disease. This is a newly described phenotype of chronic sinus disease that is prevalent in people who have inhalant allergy. And I want to use this talk really to discuss what is CCAD, how to identify it, and some of the research behind it. So this is a classic example of someone who is relatively young, in their 30s, has childhood asthma, very bad allergic rhinitis, and they get a CT scan and they're declared to have chronic sinus disease. And I'm going to hope to show you today that this is not classic chronic rhinosinusitis, but in fact a phenomenon called Central Compartment Allergic Disease. And if you look on the left-hand side, what characterizes this scan is that the inflammatory changes are all occurring in the central or midline part of the sinus cavity. Apart from some mucus trapping or fluid within the maxilla, the rest of the ethmoid cavities are all happening centrally or in the midline. Now, it's very important. I always believe actually many of our respiratory colleagues are a little bit smarter than us. They're ahead of the game when it comes to research, often when we talk about airway inflammation. And this great article was published by Sally Wenzel about asthma phenotypes many years ago to describe the state of asthma research. And she described here where we have severity on the vertical axis and age of onset on the horizontal axis. And I'm going to use this diagram from Sally Wenzel's work to describe how I see some of the disease process that we see in the upper airway that mimics this phenomenon in the lower airway. Now, the first one here is this group that are very young. So this group here, which we call the allergics. Now, these are people who often will say, I've had sinus my whole life. They have classically hay fever and allergy symptoms. And if they do have asthma, it's a classic childhood asthma. It may still not be with them now as an adult, but they have a history of it if they're going to have asthma. It's not an asthma that came on in their 30s or 40s. It really is a childhood asthma. And this is because the entire condition here is allergy. It's an IgE-mediated disease process. How do we pick it up? Middle turbinate head edema is an incredibly strong sign of inhalant allergy. So here are two examples in which maybe some physicians might call polyps. It is not, though. It is a polypoid edema of the middle turbinate, and this is a strong marker for inhalant allergy. Anisa Hamazan, who was a PhD with us many years ago, did this study where she looked at the degree of edema of the middle turbinate head and then looked to see whether or not that correlated with allergy status in patients. And what she showed here, that if you have polypoid or diffuse edema, you have an incredibly strong positive predictive value that you're going to have inhalant allergy. Now, it may not be sensitive, so there may be patients you miss here because allergy is very common, but when you see it and when it starts to occur in patients, it almost always means you have inhalant allergy. And it can be so significant in some of our patients that they're believed to have terrible polyposis. But here you can see the sinus cavity is normal. But this person has these grade 3 polypoid degeneration. This is not nasal polyps, but in fact, very severe edema and polypoid change coming off the middle turbinate. It is a sign of inhalant allergy, an exuberant allergic rhinitis. Here's an example of someone else. Once again, this exuberant allergy response with polypoid degeneration, edema, the middle turbinate, presents as a grade 3 polyp in the front of the nose, but as we go back here, you can see in the sinus scan a completely normal sinus cavity because this person has inhalant allergy. Now, if you understand that, you will understand John Delgadio's work on central compartment atopic disease. John, many years ago described the characteristics of a group of patients who were presenting with very severe inhalant allergy symptoms and had this appearance in their nose where they had this polypoid-like edema coming off the turbinates and the septum, and it was all degenerated, but actually the sinus cavity was relatively normal. So when you did a scan for them, they had this sinus approach where often the superior and lateral parts of the sinus cavity were spared. And he coined it Central Compartment Atopic Disease. Now, Anisa, who worked with us for many years, put some data to this. So she looked at 106 patients who came in who had sinus changes on their scan, and she classified the phenotype that you could see radiologically as whether or not it was a completely normal sinus, superior and laterally spared, diffuse thickening, and completely opacified. Now, what she then did is she broke the patients up into non-atopic and allergically sensitized patients. And there's not a huge difference here in the group, apart from the fact that the allergics were slightly younger, as you would expect. But in this group of patients who had sinus changes, if they had this type of picture, what we ended up calling phenotype B1, it actually best related to allergy status. We went through several different phenotypes, but this one here best related to inhalant allergy. Now you might look at the numbers and say, look at 70% versus 45%. But if you think of the fact that allergy is very common in our community, especially here in Australia, so it's 20 to 30% of the population, plus all the confounding factors that come into play here, the fact that you can pick someone's allergy status just by the pattern of their disease, I think is quite a significant finding. Now, it's important though not to take just one research group's data. So Ed McCool here described at the same time this middle turbinate polyposis is different from sinonasal polyps. And this is a great study because what he showed here is that patients with true polyps coming out of their sinus cavity and middle meatus clinically were very different from this middle turbinate polyp group, which is essentially the inhalant allergy central compartment group that we're describing. He compared the clinical characteristics, and as you would expect, they were younger because they're more consistent with inhalant allergy. They were far more likely to have allergic rhinitis as a diagnosis as well, and less likely to have severe eosinophilic disease. And similarly, when you looked at their scans, they had much less severity on the Lund-Mackay score and generally were less symptomatic. Now, just when I thought John Delgadio, Ed McCool, and myself had described something novel, Valerie Lund was listening to my presentation one day and said, "Richard, that's the black halo sign. I've published on that." And I couldn't find it. But sure enough, she did. And here we are looking at an endoscopy of someone with this inhalant allergy phenomenon. And when you look at this scan here on the left-hand side, this was one of our fellows, came back and it said to me, "Richard, I was sent a 19-year-old girl who had given the diagnosis of sinusitis." And this was her scan. And as you can see on the scan, there is really just central thickening here. There is no real sinus disease laterally. And you can imagine when you have edema that you can see here on the right-hand side on the video, this is what it ends up giving you. And for this lady, all that's happening is that this part of the nose, the central compartment, has become thickened, and peripherally everything is spared. And in fact, Valerie did publish on this, and she actually described in this book called Investigative Rhinology. I couldn't find a scientific article. Forgive me, Valerie, if there is one, but you even put a classic case of central compartment atopic disease on your front cover. So the black halo sign and central compartment atopic disease are describing this same phenotype. Now, this is very different to the patient who is well until their 30s or 40s and then gets severe polyps, loses their smell, gets adult onset asthma. And it's also very different from the patient who said, "I had bad allergy when I was younger and then I was well for many years and it just came back in my 40s or 50s. This condition is really the classic eosinophilic CRS, or true eosinophilic nasal polyposis that we often describe. Now, this is not an allergic or simply atopic disease. It's not driven just by IgE. There are many other factors here. It's mainly an abnormal eosinophil or Th2 response. And this is what these patients look like. They really have quite severe inflammation, and their middle meatus doesn't look anything like the patients I showed you before. Now, how does this all fit into the current EPOS 2020 classification? So EPOS has moved, if you're not aware. We talk about primary CRS when people have CRS or sinus inflammation that's not related to another condition. And they really talk about whether it's anatomically localized or a diffuse process. It takes into account processes that occur just within one part of the sinus cavity. And here we're going to now have a look at what is the next level. It's really then broken into, if it's localized or diffuse, could be either one. Is it a Th2 or a non-Th2 dominated inflammation? Now, in the future, this may expand this category, but for now, these are two clear groups for which there is not only a scientific understanding, but also treatment options. And then there's a whole lot of different phenotypes that have been described over the years. And here's how they sort of fit in. So localized conditions that are non-Th2 include like the classic isolated sinus disease, where just you get osteal occlusion and you get focal inflammation in one anatomical area. Localized conditions are usually unilateral as well. You can get localized Th2 dominated conditions. So this is someone who gets localized or unilateral AFS, but it is really this diffuse group here that I want to show you here. So the diffuse group now is really this group here. So if you have diffuse Th2, you're going to have a group of patients here who have classic inhalant allergy or the central compartment disease, in addition to sort of the true adult onset nasal polyposis. And I think that's very, very important. So when we go back now and have a look at the actual classification as it's written up in EPOS 2020, you can see here now that central compartment atopic disease fits into this group here of diffuse Th2 dominated conditions. Now in this case though, it's an inhalant allergy, an IgE driven disease, whereas eosinophilic CRS obviously has other driving factors. Now I wanted to end on that, and thank you very much. I hope that makes the new phenotype of central compartment atopic disease very clear, and I really appreciate everyone for listening.